Good afternoon, everyone. This is live recording from Apollo Main Hospital in Chennai, Grimes Road. We are planning to do a CTO PCI for this gentleman who is in front of us. Before I go to the case history, I am Dr. Refai Showkathali. I'm a senior consultant interventional cardiologist based at Apollo Main Hospital. So today we have a gentleman in front of us. We're going to do an angioplasty. His angiogram was done in another hospital somewhere else. He's a 45-year-old gentleman who has been recently diagnosed with diabetes and dyslipidemia. He had exertional chest pain for the last few months and underwent a series of tests in this hospital abroad. His ECG showed a normal sinus rhythm with no significant changes. His echocardiogram showed an ejection fraction of 60% with no regional valve motion abnormalities. So they underwent a treadmill test, and when he put on a treadmill test, it was strongly positive with significant ST depression at stage 2 in most of the leads. So considering his TMT positive and his symptoms, he underwent a coronary angiography in his hospital, and we're going to play this in 2 minutes. I'll explain the angiography as we go along. Then he was advised coronary artery bypass surgery or angioplasty to this LAD and obtuse marginal artery. So he came to us and we did a syntax score on his coronary angiography, and the syntax score is 28. We decided that we gave an option of both CABG and PCI, and the patient has decided to go ahead with PCI. Okay, so we have at the moment we have a 7 French cordis short sheath on the right femoral artery, and on the right ulnar artery I have a Terumo 6 French sheath. So the plan was to exchange this short cordis sheath into a long sheath for a CTO procedure. I'm planning to put a 43 centimeter Arrow 7 French sheaths to give support for the CTO PCI, and I'm planning to use my radial axis, or the ulnar axis rather, as a retrograde injections to see. Whenever we do 7 French sheaths, we tend to put a short sheath and then exchange upgrade on the long, because at the end anyway we may need to do a closure devices during which time we need to line up. Wet gauze, please. So this gentleman is around 186 centimeter in height, and he weighs 105 kilograms. So I've already given 10,000 unit of heparin, and I'm going with a long sheet now. So we need an ACT in the next 10-15 minutes, because he's only 10,000 heparin on a 110 kg. EBU 4. So considering he's quite a tall person, I'm going with the EBU 7 French guiding catheter in the left system. And I need a JR4 or JR 3.5 for the right. Fix the wire. So that's the right is for the antegrade pressure. Yeah. Test, please. Sir, try not to take deep breaths. When I say, you take a deep breath, but otherwise you just take gentle breaths, okay? Yeah, now try to get the wire in. That's it, that's RCA, go. Yeah, go. No, it's a branch, but it's okay, push. PA cranial, 0.35. Okay. Inject. Yeah, okay. RL 30, yeah. Inject. Okay. Straight RAO 35. Inject. Okay. And the last one is a LAO cranial. 25 LAO, cranial 30. Wait. Inject. Fine. Okay, fine. Go and get a N Gaia 1 wire. Okay. Test. It's already there. Okay, come to cranial view, please. stop that, roadmap that, and give me a Gaia 1, Gaia first. So what we have done is we put a 7 French EBU4 guiding catheter into the left system, and then a JR 3.5 guiding catheter with the BMW wire into the distal RCA, so it stabilizes the retrograde injections. And then we took some check shots of the retrograde filling and the antegrade filling as well. So what we found is it is around more than 20 millimeter occlusion, and there are some small micro channels and collaterals being seen, and it's a big LAD distal to the occlusion. So we believe we can use a polymer jacketed wire like Gaia first to get through the occlusion, and then we can exchange on. So we put a microcatheter, Corsair microcatheter 130 centimeter to the LAD, and then we have the wire ready to go in. We exchange the run through to Gaia first wire and see whether it can flip through into the just one small injection. Yeah, we're in the right track. Okay, let's see whether we can get a retrograde once we get in there. No, that's a branch, right? Okay, why don't we get a retrograde injection? The same view. Okay, so we need to look inside. Okay, just roadmap that mile. Get a Gaia second ready, okay? It's going somewhere else, you see? Integrate test where we are. Yeah, I just need to look this way, look inside, yeah. So we may be just going parallelly, but that's okay. Okay, 1 second. Yeah, we're nearly there, okay. Speak of calcium which is pushing down. A small septal. Okay, just let's see, say the fluoro. Yeah. Yeah. Say the fluoro, man. Okay, we'll take a picture now. Yeah, we see another view as well. Yeah, so there is it. 1 second, let me just get this down. So I got my first. I started with the Gaia 1, and the Gaia 1 actually gave a penetration into the first proximal cap, but there's a lot of difficulty with the Gaia 1 for this distal cap. So I exchanged my wire into a Gaia 2 at the distal segment, and the Gaia 2 managed to get through the occlusion completely. So now I'm trying to get my microcatheter down into the occlusion spot, but I'm finding too difficult this. So in case if I can't get my microcatheter down, then I may just start ballooning, because I know my distal wire is in the true lumen from the retrograde injections. That's one of the importance of having a retrograde injection, is to confirm the true luminal wiring. So what I'm done is I'm trying to screw my microcatheter Corsair, track it down into the occlusion site. But as expected, it's quite tight to get through my. Can we show me the balloon, please, Mile? Just show me the top. Yeah, okay, fine. How much is he gone to? I'm going to 16. Okay, yeah. So I'm just did a trapping balloon. to remove my microcatheter because my microcatheter was not crossed through the wire at the segment of the occlusion. So we're going to take one more picture just to confirm the wire. PA cranial, Mile. So show me the distal end of the wire. Okay. That's okay. 1 second. So since the microcatheter was not crossing through, I'm going with the 1.5 balloon to see whether it tracks through the occlusion site. Yeah, it's gone through. That's fine. So we save the fluoro. So what the 1.5 balloon has gone through the true occlusion site. So let's start ballooning. So we need a roadmap to say where we're going to start ballooning. Okay. So we know where the lesion is. So we'll just start from there. Yeah. 4, 6, 8, 10, 12, 14. Let's get a 2.5 balloon ready, sister. Ready. Short balloon. This is 1.5 one back. Oh, we need a microcatheter back and exchange the wire anyway. Go up again. Down. Go up again. So I'm just trying to make sure the 1.5 runs through smoothly before I exchange into the microcatheter and exchange the wire to a more less radio opaque wire so we can work on into a workhorse wire. Okay. So shall we give the microcatheter, please? Well, we can trap it. Yeah, trap balloon, please. 2.5. We'll trap it before we push the microcatheter. Yeah, go up there, please, and give the microcatheter. So what we've done is we trapped the wire so I can push the microcatheter smoothly without manipulating the distal end of the wire to avoid any dissection of the distal segment or perforation for that matter. Yeah, you got the wire. Okay, let me just get the microcatheter there, and now we can trap down, please. So once we balloon the 1.5 balloon, my idea is to the microcatheter will run smoothly on this LAD and will exchange the wire. So as you can see, the micro is going down now. So far so good. Yeah, it's gone up to the distal segment. Now I'm just going to remove this guy at second wire so we can exchange to a normal standard workhorse wire, which is, I think in this case, is a run through NS I have on the table. So get the trap ready, please. We can also at this stage we can inject on the microcatheter to confirm the true lumen at the distal tip, but because I've already given enough contrast to the right side, I'm pretty confident there we are in the true lumen. So show the tip of the wire, please, ma'am. Yeah. So the microcatheter is coming out. So and then we will start working like a standard PCI procedure on the normal wire. IVUS in it. Trap down. Okay, picture. One more last picture. And then we can remove the RCA catheter out. Yeah. That's fine. So we'll balloon at the top and see. We can see there is, because some antegrade flow has started, the retrograde flow has become little less. So I don't think we need the RCA catheter anymore. Just going to remove the RCA catheter and work on towards the wire, please, standard wire. 035. Can we have a 2.5 by 12 N balloon, whichever there in my 2.58 will be better, yeah. N balloon, please, go up there. Just anyway, go up there, we may be able to, okay. 2, 4, 6, 8, down, down, down. Yeah, go up there. I know that. Down, down. Okay, N balloon, please, 2.5 by 12. Go up there. Down. Okay, go up there. We'll decide antegrade pictures. Nitrates, please. Down. Go up again, 8. Yeah. Down. So what we are doing is, just one more time, go up there. So what we have done is we exchange into a standard run through NS wire with the microcatheter, and then we went with the 2.5 balloon So we're going to give some nitrates before we take a picture to see how big the artery is. Since we know that this is the first time we're going to give an antegrade injection after we cross with the wire. So after the test shot in the first few pictures, we haven't done a single antegrade injections until now. Miles, can you line up, please? So I'm going to take a picture now of the antegrade injection. As you can see, there is maybe there is still more ballooning needs to be done distally. I have a feeling the wire would have gone through the dissection plane and came back into the true lumen, so we may need to stent longer from the mid LAD. So I'm going to balloon that distal part of the mid LAD as well. The same balloon here. So we just gently balloon it up to the distal segment and yeah, just go up there. 2, 4, 6. 6 down. So as expected, there may be some dissection in the distalmost part of the distal occlusion site, and but as you can see, the antegrade flow is quite brisk now, and we can see the LAD very clearly. The proximal LAD is a very large LAD. Just above the lesion started segment, it looks like a 3.4 or 4 millimeter diameter vessel, and distally it looks around 3 millimeters. So I think what we're going to do is we're going to use an IVUS to see where the distalmost landing zone of our stent is, and then decide whether we need to put 1 or 2 stents into the LAD. So we're going to take a picture to see where the landmark of this particular segment with the contrast, so we know where we are. So to decide the, okay, don't do any pullback and all, just stay there. Okay, put standby, Mile. Okay, so we know where the marker is. So I think we need to go down a little bit more, right? Okay, so that's a good segment where you can a nice landing segment. So put a roadmap on that. Just bookmark on that. So that's around 1 to 3.5 millimeter vessel there. Bookmark that and start pullback, Mile. Yeah. So this segment is quite big. Okay, there's not much dissection you can see on this images here.
You can see there.
No, but I can't see, it's too dark. Yeah, that is the tight part of the lesion. Bookmark there, Mile. That is where the occlusion site will come in a second. This is after 2.5 millimeter ballooning, so you can see the vessel size is actually quite larger. Bookmark that. Okay, you can see the branches coming there, the septal coming in. Bookmark that, Mile. So we're going to come to the normal LAD segment in a minute, so that's going to be a reference vessel. Bookmark that, Mile. Yeah, that's the bookmark that. Bookmark there. So that I think that's the LAD now, proximal LAD. Okay, that's left main and coming. So the last, I want from the last bookmark to the first bookmark, what is the length? I've just done a IVUS study of the LAD after ballooning with a 2.5 millimeter balloon after opening the CTO. What we can see is quite a large segment, a large LAD, and when we did the IVUS, the distal landing zone where we think we can going to put the stent is coming around 3.7 in diameter, the EL, versus 4.3, whereas the luminal segment is 2.8 by 3.3, which is average of around 3 millimeter lumen and 3.75 millimeter EL. So we're going to decide for 3.5 by 28 millimeter stent to the distal part of the LAD or the mid segment of the LAD, and then the proximal end where we think we are going to stop the stent comes around 4.5 to 5 millimeter in diameter in the proximal LAD. So what we're going to put is 3.5 first, and then put another 4.5 or a 4 millimeter high pressure at the proximal part of the LAD. So the intravascular ultrasound, intravascular imaging tell us the diameter of the arteries a little bit more clearly, considering he's a young gentleman, only 45-year-old gentleman. We need to make sure that we get very good luminal areas, cross-sectional area of the stent, so that he doesn't develop instant restenosis in the future. So in patients like this, we should intravascular imaging does give a clear idea about the size of the stent we're going to deploy rather than by angiographic evidence. As long as we land the proximal end of the second stent in a reasonable area, then we should be able to get another stent in the proximal part of the LAD. Okay, picture, long injection. 288, just give another 3000 heparin. Okay, I think that should be okay because we are anatomically we are okay. I may come back actually. Yeah, deploy that. 6, 8. 8. What's the nominal there? Just put it 10 and stop. And down. So we deployed a 3.5 by 28 millimeter stent at the distal most part of the lesion, and now I'm going to measure use this balloon to measure the length of the proximal segment I need to stent. Yeah, which exactly, so we're going to take a picture, nice injection. Yeah, so what I'm planning to do is, this is quite, we can reduce the size. This is a 28 millimeter stent. We can go with a 23 millimeter, 23 by 45 4.5 millimeter stent for the proximal LAD. I want some heparin, please. So if you're going to put a 4, we can go high pressure. Yeah, we can use a 4.5 balloon to expand post dilate the stent. 22 or 23? 24 is okay. So the ACT after 10,000 units of heparin, the gentleman is 105 kilograms. So the ACT after 10,000 units of heparin, nearly 45 minutes to an hour. The ACT is 288. So we thought we'll just give 3 more thousand heparin because we need to work on the obtuse marginal and the circumflex artery as well. Yeah. Yeah, I think 4 should be okay, Mile. 4 by 24. I don't need to. I have to go in actually. Okay. Take a cine with the 2 beats without it and then inject. Okay. Yeah, that's perfect, right? That's nicely landed. Okay, go up there. It's 2, 4, 6, 6, 8, 10, 12, 14. So having seen it's a 4.5 SL, I'm happy to go at a high pressure of 4.5. And then we use a 4.5 balloon, Mile. Short 4.5 balloon and down. Just go up there one more time. 2, 4, 6, 8, 10. 12. Okay, that's enough. So I'm trying to post dilate the 3.5 stent with a 4 millimeter balloon, the stent balloon at 12 atmospheres, giving us a 3.98 or sorry 4.12 internal diameter of the 3.5 stent. Down, please. I think that's probably enough for that. There's a lot of contrast mixing. Just take a gentle breathe in, sir. Okay, that's fine. That's okay. Just go up there. Yeah. 2, 4, 6, 8, 10, 12. So this is a 5 millimeter NC balloon we have on the left LAD artery now, down. So we're going to go not very high pressure. I'm going at around 12. Contrast is too much. Go up again, 5 at 12, 14 maybe. 14. Yeah. You can see the expansion with the 5 and down. Yeah, one more, then we'll do the stent boost. Go up again, Radha. Just go 2, 4, 6, 8, 10, 12, 14. (20 seconds). 16 and down. Okay, you want to do stent boost? Okay, IVUS. So what we're going to show now is the post-PCI IVUS outcome after doing this 2 stents for this gentleman. The first one was a 3.5 by 28, and then we used a 4 by 24 millimeter. And we know from the pre-PCI IVUS images that the diameter of the proximal LAD we got is around 4.8 millimeter, and the distal LAD was around 3.5. So after post-dilatation with a 5 millimeter balloon from the proximal most part up to 30 millimeter down the stent of the proximal stent and the distal stent, we did an IVUS image to confirm that our expansion was good and there is no malapposition in the LAD. So this is the IVUS image. You can see the IVUS image running on the screen. So this is from the distal 8 or 7 millimeter distal to the stent segment and pulling back through the stent. So you'll see the first struts of stents coming in, the distal most struts. So at this segment we stopped. I will just show you the measurement at the distal most part of the stent. At this part is 6.69 millimeter square. So this is the cross-sectional area at the distal most part of the distal stent, which is the 3.5 millimeter stent, which is giving a diameter of around 2.75 by 3, and there is no distal dissection noted. So when we come back, you can see the good apposition of the stent with the good expansion as well, you can see the cross-sectional area is reasonable, and there is no evidence of tissue prolapse into the coronary artery of the stents. And the most important point I want to know is the proximal most part of the proximal stent. So this is the overlap segment of the 2 stents. You can see 2 struts coming, and you can see this is the 4 millimeter stent, nicely expanded all throughout. And I'll coming back into the proximal most part of the stent. That is the proximal most part of the stent, and there is no proximal dissection, and this is the proximal LAD. So let me stop here and go by frame. If I want to go from proximal to the distal, imagine this is the LAD. It's quite a large LAD, as we discussed. It's around 5 millimeter LAD, and this is the most proximal part of the stent, this segment, and it's what we are getting is around 13, but I think this is little bit. If I go here, you get around 14 millimeter square of cross-sectional area at the proximal part of the stent. Now this is after 5 millimeter expansion. You can imagine. So this is one more. I'll show you 1 or 2 more. So this is 15.36 at the around 3 millimeter distal to the proximal edge of the stent. So I think what we were happy that we managed to get a good expansion of the stent with a 5 millimeter balloon. I mean, there may be some argument that we can go up more pressure with a 5 millimeter balloon, having seen there are some plaque burdens, particularly in the 9 to 12 o'clock position. But at the same time, we need to be very careful in expanding 5 millimeter balloons at high pressure. We may end up causing dissection. It's a balance between avoiding dissection and getting a good expansion. And in the proximal LAD, if you achieve a 15.36 millimeter square cross-sectional area, I think that's well enough for this gentleman to continue live without any symptoms. Remember, his symptoms is more stable angina, which is exertional chest pain on exertion, and the treadmill was positive. And I'm pretty confident that this expansion will give him a better quality of life in the long run. And I think, having seen this, I don't think there is a very high risk of restenosis with this amount of 4.5 or a 5 millimeter stent at the proximal part of the LAD. And the LAD was having a TIMI3 flow. And geographically as well, you can see that the flow in that LAD was extremely great. These are the images we are seeing. Remember, after doing the LAD, my associate consultant did the PCI to obtuse marginal, because I'll show you the pictures. We were debating whether to do anything to the circumflex, but after taking a few pictures, we decided the circumflex stenosis is not needed for this 45-year-old gentleman. So this is after putting the LAD stent. I'll show you these pictures. So that's the post-PCI LAD flow. You can see it's a 5 millimeter, 4.5 millimeter stent, and it's a good flow into that LAD. On this view, then we decided this is the IVUS run, and then we decided to take picture to decide what other arteries we should do for this young gentleman. So there is a debate about whether we need to do something about the circumflex, and considering he's young and it's only stable angina, I decided to leave this for medical therapy, because I believe there's around 50 to 60% stenosis, and having seen the ischemia trials, I think we should not unnecessarily do angioplasties for young gentlemen unless there's real need for it. Whereas this obtuse marginal, which is a good size obtuse marginal artery, has got significant stenosis, which is also seen on the cranial view. If I show you the cranial view, you'll see that the obtuse marginal had a very significant stenosis, and I think that is one of the reasons why we decided to treat that. Sorry, I'm just going to show you the lesion in the obtuse. So she wired the obtuse marginal, and with the took a picture with the marker wires, and you can see it's around 28 to 30 millimeter length in length for the angioplasty stent for. But this is the cranial picture which I was talking about. On this view, you can see the obtuse marginal is quite significant stenosis, which is not very clearly seen on the caudal view, whereas the circumflex, on the other hand, has moderate stenosis without any significant areas of stenosis. She used a 2.5 balloon to predilate the lesion in the obtuse marginal, and I think this is a 275 by 28 millimeter synergy drug-eluting stent being deployed in the obtuse marginal at around 12 atmospheres. I think the stent expansion looks okay, but then I think she used a 3 millimeter balloon to post-dilate the stent at that segment, and this is the final result of the obtuse marginal artery. So overall, this young gentleman with the CTO of the LAD has a JCTO score of 3, because you have some calcium, lesion length of more than 20 millimeter, and there is a long length, and that gives him a JCTO score of 3. And then we did angioplasty and opened the CTO with a Gaia 1 and then a Gaia 2 wire antegradely with a retrograde injections, and we managed to do an imaging, particularly because as a young gentleman, you want to make sure that you want a good result for him and prevent him coming back to the cath lab. So imaging has helped us to expand the stents with a 5 millimeter at the proximal most part of the stent, and we had a fantastic results with the MSA of around 15 millimeter square at the proximal LAD. And then we decided we did a angioplasty to the obtuse marginal PCI to the obtuse marginal artery, which has got a good flow. And then what we did is we removed the long sheath in the femoral artery, and we exchanged to a short 7 French sheath, and we did an imaging of the femoral artery before we decided to put a angioseal closure device, 8 French angioseal to the right femoral artery, so he can sit up and mobilize quickly. So I think this clearly demonstrates the importance of imaging, the importance of methodical approach for this gentleman, 45-year-old gentleman who was advised a bypass, but we gave an option of both CABG versus PCI, with the syntax score being 28. This is an intermediate syntax score, and we know the 4-year outcome can be equivalent with intermediate syntax score. There is no left main stem involvement, and with this, I think I'm quite happy that he will do well with these results, and I'm going to discharge him maybe tomorrow or day after, depending on his progression. Thank you for listening, and thank you for listening to the talk and going through the case, and I'm sure there's a lot of learning points in this, and we hope to see you again in the future.